Okay. Whilst everybody comes in, we'll just give them a few minutes and then we'll start with the attendees' rules of engagement. Okay. All right, so this webinar is being recorded. No one can see that you are attending unless you would like to ask questions. So if you'd like anonymity during the question and answers, please tick the box to send anonymously before sending your question. We hope to make this webinar as helpful to you as all as possible, so please do ask your questions in the question and answer section. You may ask the question at any point, but they'll be answered after all the talks. If we don't get through our questions in the allocated time, it'll be around 45 minutes for this evening, we'll answer them via email after the session. Okay, tonight's agenda, or this evening's agenda, I'll be doing a welcome. Dr. Razina Patel from Stanton Fertility Clinic will be talking about Polycystic Ovarian Syndrome. And Nivashni Nair Sukdhev, journalist and author of What's on My Mind, Making Babies, will be talking about her personal journey to motherhood. And we'll wrap up then with a question and answer session. Okay, so thank you to everyone for joining us on our second webinar for Reproductive Health Month. My name is Saskia Williams and I'm the founding director and CEO of IFASA. I'm proud to be bringing the Reproductive Health Month campaign and webinars to you in association with Michelle and Lucia of House of Fertility, as well as the IVF Babel Africa team. We are bringing you webinars every Tuesday and Thursday evening throughout February, featuring local and international speakers and specialists. We are also running a campaign for early diagnosis of infertility, and participating clinics are offering 25% discount on their initial consultation and scan fee. Please check out our Reproductive Health Month website for further information. Let's get started on tonight's lineup. Our first speaker is Dr. Razina Patel. Dr. Patel is a specialist at Stanton Fertility Clinic, and she's going to be talking to you tonight about PCOS. Over to you, Dr. Patel.
Thank you. Okay, good evening, everyone. I just need to get my slides up, and then I can start my discussion. So share screen, Saskia.
Yeah.
Okay, I think it's at the back of this. What happens if I do that? No. Oh.
Are you battling? Did you do the green share screen at the bottom?
Okay, so I'm starting there again. Share screen. Okay. Doesn't do much once I'm there. Let's just try again.
And then select the window that the presentation's in.
Okay, let's go there. Okay, I think we're there.
And then choose share.
And then choose share. Let's go for this screen a bit faster. There we go.
There you go. Yeah, perfect.
Thank you.
Okay.
Okay, everybody. Good evening. I'm Razina Patel. I'm here to talk to you about Polycystic Ovarian Syndrome. To start off with, Polycystic Ovarian Syndrome is a hormonal imbalance. Most people are familiar and even comfortable with the phrase hormonal imbalance. I beg your pardon. I'll start again. Most people are familiar and even comfortable with the phrase hormonal imbalance. We blame hormones for everything, from libido to infertility. In fact, we like to be told that we have a hormonal imbalance because that means we can fix it. Somehow, though, being given the diagnosis of Polycystic Ovarian Syndrome is suffocating. It's like standing at a precipice with no way back. I'd like to tell you that Polycystic Ovarian Syndrome is just a fancy name given to a subgroup of this friend called hormonal imbalance. And it's just as manageable and tameable if you pay enough attention to it. It's just stubborn. Let's understand why it's stubborn. The normal menstrual cycle requires a certain type of hormonal music to be playing. The key players in that hormonal music are the brain, the pituitary, and the ovary. As you can see on the slide, a special area in the brain called the hypothalamus secretes GnRH. That's the master hormone, gonadotrophin releasing hormone. It goes to the pituitary gland and makes that gland release two hormones called FSH and LH. Those two hormones then go to the ovary, and they have to tell the ovary, I'm trying to get the next slide there, give me a second. Give me a second, page down. Okay, sorry, hold on there. My slide is not changing. Oh, don't understand. Okay, there we go. All right, so the FSH and LH then go to the ovary, and they stimulate different parts of the follicle to make it become mature. Cells called granulosa cells respond to FSH and they feed the ovary, they feed the egg, and the theca cells then produce some male hormone, all of which results in a mature egg being released out of the ovary into the fallopian tube. That is the magic and the hormonal music that results in a regular menstrual cycle. Every month, all these hormones work together to make the egg ready to let it release and to give you a regular timed menses. The abnormality in hormonal imbalance, the abnormality in polycystic ovarian syndrome is because the brain starts misbehaving. It doesn't give you enough GnRH in the right way. That results in the pituitary gland producing too little FSH and too much LH. When these abnormal levels of FSH and LH reach the ovary cannot do what it did normally, because FSH doesn't allow, the reduced amount of FSH doesn't allow the egg to mature, and the elevated level of LH causes too much male hormone production. The excess male hormone production will then inhibit ovulation, which means that this month, this egg does not get released. And if that happens, your menses will not be on time. That's what makes people with Pcos not have regular menses. If we look at what happens in two different scenarios, one a normal ovary and the other one a polycystic ovary, you will notice, if you can see my arrow, that in the normal ovary, the egg that matures will be moving slowly over the ovary from the left to the right, accumulating fluid and growing, and then being big enough to be, give me a second, then being big enough to be released into the tube. If this doesn't happen and the hormonal music is abnormal, the follicles do not mature and the egg stays stuck inside the ovary and then accumulates in a pattern that looks like a pearl necklace. So the ovary on the right-hand side, being the polycystic ovary, has got lots of eggs that tried to mature and couldn't because the hormonal music was wrong. And because they cannot mature and escape into the tube, they accumulate in the ovary and make a pattern of bunching up of follicles and either a honeycomb pattern or a pearl necklace appearance. So these cysts that are in the polycystic ovary are not abnormal cysts. They have started off in the usual way, containing eggs. We call them follicles when they contain eggs. Why are we suddenly calling them cysts? So actually this condition should be called polyfollicular syndrome, because the follicles that are there normally have just increased in number because they are immature, they're stuck in second gear, and they cannot jump out of the ovary. If you call the ovary polyfollicular, you wouldn't think it was as abnormal, because polycystic means that your ovary is doing things it shouldn't do. Polyfollicular means you're doing what you should do, but you're just not getting it all correct. It was misnamed polycystic ovarian syndrome in the very beginning, and the name has stuck. So if we then look at what the problem is with this friendly hormonal imbalance, let's say that I have described, as I said to you, that a hormonal imbalance makes it look like a honeycomb because of eggs just don't jump out of the ovary. But how big a problem is it for us? Effectively, it affects 1 in 10 women. That's a lot in reproductive age. It is the most common hormonal disorder that we find. 6 to 10% of women between the ages of 15 and 44 will have it. Some people know they have it and some people don't. Pcos makes up 80% of the women who see us at fertility clinics, and we're not scared of it. It is manageable and controllable, and you get to where you need to go to, provided we all do our work correctly. If we look at how do you get to have polycystic ovarian syndrome, the cause of the hormonal imbalance is not always fully understood, but there is definitely a genetic predisposition. So if you have the syndrome, your sisters and daughters have a 50% chance of developing it too, and ethnicity also plays a part. Once you have a genetic predisposition, how you live your life and your environment and your lifestyle can also affect whether it manifests and how severely it manifests. So diet and exercise are important, and it's important to tell family members of such a condition running in the bloodlines. Because metabolic syndrome, which is actually also very common in families, is eventually where we end up if we have polycystic ovarian syndrome. Actually, we have it and we will end up with diabetes, insulin resistance, blood pressure, and cholesterol problems with heart attacks and the sequelae thereof. So how do we then align insulin resistance with polycystic ovarian syndrome, knowing full well that the full picture will evolve over time? How can we work with what we have, seeing Pcos in young people, knowing that they are destined by genetics to end up with some degree of these major health conditions, and knowing that we can have an opportunity to modify how severely they present. When your diabetes presents, how severe it will be, how much you've learned to modify its manifestation, and how much of the consequences will you bear because you either controlled your diabetes well enough or you didn't. So if we look at, I'll go to the slide first, the main player in Pcos is insulin resistance, because high insulin levels in Pcos women cause high testosterone production from the ovary, just like LH did. Early on, we said LH goes to the ovary and makes high testosterone levels. Even insulin goes to the ovary and makes high testosterone levels. And those testosterone levels cause follicular arrest and lack of ovulation in the ovary. So the insulin resistance is a major problem, and it is related to weight gain. So if you start off with insulin resistance, means your insulin levels are high. What does insulin resistance actually mean? When we eat anything containing glucose, the glucose levels in our blood increase. And the body then needs to store this glucose in the cells because it cannot circulate levels of 20, for instance, in the blood. So it packs away some glucose into the cells to be released later when it needs it. The mechanism by which glucose is put into the cells for storage and for use later on is based on the molecule called insulin and the receptor called the insulin receptor. The problem with insulin resistance is that the receptor changes shape. And so when glucose is trying to enter the cell, the lock and key mechanism is no longer working. The insulin molecule can no longer unlock the door because the key, the lock is the wrong shape. So the body compensates for this by increasing insulin levels. So with high amounts of insulin, many keys, the lock is forced open and glucose enters the cells, which means that your blood glucose level has gone down to what it should be, under 6, because the system has compensated for your problem being that you have the wrong shaped locks. So high levels of insulin circulate in the body in order to prevent you from being called diabetic, because if that glucose level stayed above 6, you would be diabetic. So the high insulin levels then cause many problems, including fat storage. So we then start accumulating fat around the central tummy area, and that's called central adiposity. Most people will complain that they work very hard in the gym and they eat very well, but they just don't lose the fat around their tummy. And that's because the insulin is elevated. The insulin produces more testosterone in the ovary, and that causes the acne, the hair growth, the irregular periods, and the infertility. So it's a vicious cycle of high insulin causing weight gain, excess weight, enhancing the insulin resistance, and it's a trap. So insulin resistance, PCOS, long-term diabetes, they're all connected, and it's a very important aspect of fertility that we need to work with, because high levels of insulin will prevent our treatments from working, and we won't be able to help the ovary to ovulate unless we get the insulin down. And the way to get the insulin down then is related to diet and exercise. I will come to the insulin and how we treat the insulin levels in a short while. Let's go to how we see Pcos from the outside. So most people complain of irregular menses, the acne, the excessive hair growth, upper lips, arms, around the nipples, centrally on the middle line of your abdomen. Some people have hair loss on places where they want hair, example on their head. I've talked about difficulty losing weight. I must also emphasize that certain people with Pcos are actually quite slender, and some of them actually have regular periods. So we used to say that all people with Pcos have got overweight, but now we say we have lean Pcos patients. All people with Pcos have irregular periods, but sometimes we have ovulatory Pcos patients. So there is a variation now in how people present, and we still call them, or we still say they have Pcos, because actually giving you a diagnosis like Pcos is not because we want you to carry it around your neck like a noose. It's because when we have a diagnosis, we have direction, and when we have direction, we can help you. Like I said, infertility due to the lack of ovulation can happen in some women, but not in all. Remember that with all this trouble falling pregnant, with all the hair growth, the difficulties with grooming and acne, we do have psychological distress for these patients, and mood disorders are also found to be somehow more common in people with Pcos, maybe not even related to the way their bodies are betraying them, but also somehow there is some chemical interaction, it seems, between Pcos and mood disorders like bipolar mood disorder. There's also thick dark skin developing on the neck and the underarms and the groin in some people. The hidden symptoms of Pcos are usually, as we said, the pre-diabetic and the diabetic. Lots of women will develop, 50% of women with Pcos will develop diabetes sometime in their life, by the age of 50, they say. The insulin resistance, the high cholesterol, high blood pressure, weight gain and obesity. Sleep apnea comes with increased body weight and obesity. It is quite a dangerous condition and can lead to unexplained demise in your sleep. The risk of cancer, such as uterine cancer, let me explain that before it gets misinterpreted. The problem with Pcos is that if you don't ovulate and if you don't produce the right chemical music to allow shedding of the lining, so that means a period. If you're not getting regular periods, menses, and the lining is not shedding, it can get thicker and thicker, and eventually in that thick lining of the uterus called the endometrium, you might get malignant changes occurring. So if we can help women who are not menstruating regularly, naturally, to shed that lining, we overcome this risk of cancer. It's just unattended thickening of the lining that people are not bringing to our attention, and we cannot help you with. So it's not really automatically a risk for cancer. Pcos is not automatically a risk for cancer. It just talks about the lining that is not regularly shed. And so the treatment options that I'm going to share with you in a short while negate that. So don't take that out of context. So women with Pcos also have 3 times the risk of diabetes, stroke, and heart disease, twice the risk of anxiety, depression, and following on that, drug use, twice the risk of hospitalization for any cause, and 10 times the risk of infertility. Sounds like a sentence. It's not. It depends on how you look after yourself, and it depends on what you do to actively overcome what nature has put forward for you. So there are ways to work around it. Let's talk about those as we go on. Remember that Pcos can also affect pregnancy. Once pregnant, a woman with Pcos can have early miscarriages, gestational diabetes, premature delivery, small for gestational age babies, high blood pressure of pregnancy, and the perinatal mortality talks about loss of babies around the time of birth, just after, just before. So those are loaded concepts, and it's almost like it doesn't leave me even when I did fall pregnant. But there's so much more chance of things going well than not going well. So don't take this with you into your pregnancy. Know that there's more chance of things going well than not going well. So the treatment for Pcos symptoms, but not for the underlying condition. Let's go for symptoms. So we can help you with ovulation induction for infertility. So we just have to change that hormonal music, and we could facilitate an ovulation. People who don't want to fall pregnant but want to fix that hormonal music, we use the oral contraceptive pills. The reason why we use it is because if we were going to give you hormones that your body normally produces, we would be having to tailor them according to the way the cycle works. And the contraceptive pill pack is readily available, convenient, easy to use. So the contraceptive pill pack for those who don't want a family yet and who are having irregular periods, because it also helps that very confused ovary that's producing so much male hormone, it makes it go to sleep. And if it goes to sleep, it won't be producing the excess of male hormone that I talked about earlier. And so without that excess of male hormone levels, we won't have acne and hair growth. Finasteride is also an anti-male hormone chemical that will also help hair production, hair growth to be less. Before we leave that, those 2 points, let me add that sometimes the oral contraceptive is blamed for people who years after starting the pill come off the pill and try to have a baby. Now remember that when you're having acne and hair growth and irregular periods and you're a teenager, you will get put onto the pill by someone, your family doctor, your neighbor, your pharmacist, your friend, because that's a common practice. But if you have an ovulatory disorder and a hormonal imbalance that necessitates that control in your teenagehood, when you use the pill is not curing your condition. It is merely suppressing the ovary. So that's what the pill does. It puts your wild ovary to sleep. And if your wild ovary is asleep, it won't be producing the male hormone it would otherwise. And when you come off the pill, 10 years later, your wild ovary that has been put to sleep by the pill suddenly wakes up and it's still wild, which means that it will still produce the excess amount of hormone, male hormone. It will still be difficult for it to ovulate. So you will then probably have the same acne, the same hair growth, the same irregular period, and the same lack of ovulation that will lead to difficulty falling pregnant. So lots of people say, I went on the pill at 18, now at 28, I'm off the pill, I have irregular periods, I have an ovulation, lack of ovulation, and I can't fall pregnant, look what the pill did to me. But had you tried to have the baby at 18 or 28 with a wild ovary producing too much male hormone and being confused, that ovary being confused with the wrong hormonal music, your difficulties would have been the same. So when we put people on the pill, we have to explain to them that the way their ovary behaved pre-pill and post-pill will be the same. As far as science is concerned, the pill does not prevent you from going back to your regular cycle, nor does it prevent you from going back to ovulation, nor does it interfere with your ability to fall pregnant. It's the inherent ability of your ovary to either make the correct to perform the correct ovulatory function or not. So let's go further than that. So we think chemicals to correct the hormonal imbalance so that we can either make eggs or we can quieten down the ovary, depending on whether the patient wants a baby or just wants regular menses and wants help with their acne and hair growth. Beyond that, the big problem of insulin, we can help with metformin or glucophage. There's a slide on that I'd like to talk about, but for all intents and purposes, glucophage lowers insulin, and the lower insulin will be less negatively influential on the ovaries. Remember, insulin prevents the ovary from ovulating, and it also makes the ovary produce male hormone. So if we lower the insulin level, the ovary will produce less male hormone, and it will be more likely to ovulate. What we need to do in addition to trying to lower insulin levels with chemicals is we also need to do it with exercise and healthy eating. And there's a slide that I'm going to jump to now, which, okay, I'll go back there. Okay, let's go to this. How does diet affect Pcos? So the fact that we want to bring the insulin level down means that we have to do the right thing in terms of what to eat, how to eat, when to eat, and how to exercise. The low glycemic index diet is the way to go. It produces less sugar spikes and gives you more stable insulin levels. And your nutritional needs must be met because you're going to try and be pregnant. And from these variety of foods, you can choose low GI, anti-inflammatory food substances that will allow the body to align itself with the overall program. So if we leave diet and exercise and go back to the last 2 points on treatment for Pcos symptoms, we must remember to manage psychological and emotional elements of the condition. One of them being that Pcos is not a life sentence. I always say to patients, make friends with it, because there will be times when it will be roaring and other times when it will be whispering. And if you keep it whispering, then it will be your friend, and you will be able to work around how it holds you back, because there are ways of making you on top of it and not it on top of you. General sleep hygiene, which means have good amount of sleep. Things like acupuncture, definitely counseling, support from people affected by Pcos and from people who understand your condition and are sympathetic with your problems. All the ideas about healthy living are important to help you get to the point where our medication and your efforts can work together to facilitate ovulation and pregnancy. And getting healthy before you fall pregnant is also important for the pregnancy itself. To go into a pregnancy overweight is also no good. And complications arise from the weight problem. And a lot is being said and written about the baby's future metabolism that is related to how the mother eats in pregnancy and the mother's insulin levels and the mother's BMI. So keeping yourself healthy to fall pregnant and to have a healthy pregnancy is important for you and for your baby. So in terms of what we use to drop the insulin level, besides everything that I've said about what you eat and how you get the weight down, when I talked to you earlier about the lock and the key mechanism, why is glucophage stroke metformin a good idea? That lock that I said to you has changed shape. Glucophage changes it back to its original shape. So it is an insulin sensitizer. It is used by diabetics, and so it is quite stigmatized. And I often tell my patients, when you go to the pharmacy and you say to them you want metformin or glucophage, let them not ask you if you're diabetic, and don't get worried by the fact that I might not have told you that you're diabetic. And don't be afraid if your gran is using the same tablets, because she is diabetic. Because all it is an insulin sensitizer that can be used for insulin resistance or for diabetes. So when you use it in insulin resistance, it will change the shape of the lock back to what it was, which means at some point when you start using glucophage, you will be in a bit of trouble for the following reason. Not only do you have locks that are now easily opened because they've gone back to their original shape, but you also have lots of keys floating around. Remember, your insulin level went up because of the resistant and stubborn lock Now you've got a lock that's back to where it should be, and it opens easily, but you also have numerous amounts of keys. So when you first start taking it, we start you on a low dose, and the low dose then helps your body to realize that something's changing. So the insulin level drops now because the locks are easily open, and it realizes that it doesn't need to force a lock open. So most people, a lot of people, when they get tired, nauseous, sometimes a bit of diarrhea on glucophage, they decide that they cannot use it. If you start with a low dose, you will work up to a better dose, but if you can persevere, your body will balance itself out. The other thing not to do when you're taking metformin at night is a lot of people who have then gotten used to dieting then will have no carbohydrate at night. And if you have no carbohydrate at night, when you take the metformin, it's saying, come on, you've got extra glucose in the system, let me hide that in the cell and make the lock easily opened. But if you didn't take any carbohydrate, you don't have excess glucose in your bloodstream. And as much as the locks are easily opened and the keys are there, your levels of glucose in your bloodstream dive significantly because you didn't have enough to eat that loaded the bloodstream with glucose anyway. So be careful of making bad friends with metformin. It does have a place to play. Let yourself get used to it. Don't stop taking it too soon. Adjust your diet, speak to a dietitian, start with low doses. If you cannot move up to the higher doses, persevere with the lower doses. Because as far as we are concerned, we use it a lot. We like to work with evidence-based medicine, which means that something must be proven to be of use before we give it to our patients. Sometimes if there's no harm in using it, but we practically on the floor in our clinics see that it works well, we do use it. Metformin is one of those. We see it work very well. People shift their weight and they don't get frustrated because they are exercising and eating so well and getting nowhere. So metformin, as far as I'm concerned, helps weight to shift. It's not a weight-losing medication, but it makes your efforts pay off so you don't get frustrated and stop doing all the good work you're doing. So last line says used by doctors, but not evidence-based. Doesn't mean it's bad for you. From here, the treatment of infertility. So when we're talking about how we help you make an egg ready and release an egg, this picture that I've got needs to have a line drawn between normal cycle and bleed and polycystic cycle at the bottom. So there are two different pictures. If you look at a normal cycle, day one is the day you bleed, and the hormonal music, as you can see, is quite jagged. It's a jagged line that shows us how the hormones make the egg grow from being a small follicle to a big follicle containing a mature egg in it. At that point, the body will ovulate. If you look at the polycystic ovarian syndrome cycle, day one of the bleed takes you into a hormonal music that is almost wave-like. I call that the wrong hormonal music. So if we want you to make eggs ready, all we have to do, sounds simple, but it's not that simple. I'll tell you why just now. We have to change the wave pattern to the jagged pattern. So we give you medication, hormones as well. We can only fight hormones with hormones. We give you hormones as well on day two of the cycle to make the wave pattern become a jagged pattern so that we don't have the small follicles of PCO accumulating because we can't mature them. The reason why I said it's simple but not so simple is because polycystic ovarian syndrome ovaries are somewhat stubborn. They have a lot of follicles in them that are jam-packed. They also have a lot of hormone, male hormone jam-packed in that ovary, and that ovary is just not willing to listen. So when we do ovulation induction with medications, yes, you're right, with medications like Clomid, Fertomid, one and the same thing, Femara, injectables, we are trying to tell this ovary that we are in charge and we want you to do it our way. The ovary sometimes doesn't listen, and we have to change from one medication to another. It's also what I call a hysterical ovary, because sometimes when you think that you have put the dose correct to make it listen, it overreacts. So it doesn't react when you give it a little. You increase your dose a little more, and suddenly it's overreacting and making too many follicles. Nevertheless, with hormonal manipulation, we can make an egg ready in a polycystic ovary. having taken care of other things like the male hormones and other things like the insulin. So preparation from your side, dropping insulin levels with weight loss, maybe using the drug called finasteride to drop the androgen levels, male hormone levels, will make our medication more effective and the ovary more likely to listen and cooperate with our instructions from the medications we are giving you. If we talk about ovarian drilling, let's say that when this ovary is jam-packed with follicles filled with male hormone, in the past, we were a bit confused about what's the best way to do that. So science used to do doctors used to do what we call wedge resection. So this ovary needed to be rid of some of the male hormone that was trapped in those follicles, because that's what made the ovary so stubborn. So we then used to take you to theater, cut almost like a slice of cake out of this ovary, a wedge resection of the ovary, because in that slice of ovary, were lots of follicles filled with male hormone. So overall, what we thought we achieved is that the overall burden of male hormone in that ovary was reduced because we removed a wedge with quite a lot in it, quite a lot of trapped male hormone in it. But what we also soon realized is that many good follicles that could have served us well were also being removed. So wedge resection of the ovary is no longer done. What we tried to do thereafter is what we called ovarian drilling, which means that at a laparoscopy, we take a heated needle and we puncture a few holes into the ovary, hoping to be able to go through a few follicles that are filled with male hormone and helping that male hormone to come out of the ovary just as we stuck the needle into it and the fluid just oozed out of it. So we did that, multiple punctures in the ovary to hit a few follicles containing male hormone so that we could reduce the load of male hormone in those ovaries. We realized we were doing the same thing also, that along the track of your needle are many good follicles that you are destroying, many good eggs that you are destroying. So now multiple ovarian drillings are not done, and we are advised to maybe do 1 or 2 in each ovary. Mostly now we manipulate the ovaries chemically to try and decrease the amount of male hormone in them, which is that finasteride that I talked about. And so most of our ammunition that we use now for polycystic ovarian syndrome is mainly chemical. So I have gone through what it is and that it isn't such a bad monster. I've gone through how common it is in our fertility clinics and how not challenged we are by it as an entity, which doesn't mean that it's always simple to work with, but it means that when you walk in with polycystic ovarian syndrome, we don't think that this is the most difficult case we ever came across. In fact, we think we know this monster, we know how to tame it, we work together with you to bring it to its knees, I want to say, and make it work for you. Like I said, it's sometimes roaring and it's sometimes whispering. You have control over that. We have some women who needed to have ovulation induction for their first pregnancy. After the pregnancy, they say, I'm not going on any contraception. When I need to, I'll go back to the clinic, they'll manipulate my hormones. And before you know it, she's pregnant because she had a spontaneous ovulation. We don't say that we can cure it, we can manage it. And with your help, we can keep it tame and we can make it work for you. We can, hopefully with the powers that be and the universe on our side, we can limit the hindrance that it is to you. We can help the ovulatory function to return, and we can make healthy babies and give you hope for the future. So it isn't the worst thing. Make it your friend, work with us, and we look forward to helping you in our clinic. Thank you, Saskia.
Thanks, Razina. That was a wonderful talk, as always. We really do appreciate you giving us your time and your expertise with these issues. So thank you.
Such a pleasure.
Okay. Our next speaker is Nivashni Nair Sukdhev. Nivashni is an award-winning journalist and the author of What's on My Mind, Making Babies. She's going to talk to you tonight about her personal struggle with PCOS. Okay.
The year was 2014. I weighed 99 kgs. My face was covered in cystic acne. My hair was suddenly coarse, and I hadn't had a natural period in months. I was moody. I snapped at my husband. I was unhappy at work, and I didn't want to socialize. I was on a downward spiral, and something had to be done. So I made an appointment with the doctor that I had seen in 2009. He didn't recognize me when I walked into his rooms because I wasn't that young bride who was so happy and looked so good. My Pcos was out of control. He sent me for blood test, and it came back that I needed to really take on Pcos. Do you want to develop heart disease, be on insulin, die young? These were some of the things he told me. And the treatment could not be found in a pharmacy. It had to be weight loss. And I'm just going to read something from my book. After he gave me his eating plan and prescriptions for testosterone blockers and metformin, I drove home and I thought of a million reasons and excuses why I should not follow through. The most obvious reason was that it was easier to do nothing about Pcos. I could eat cake every day. Just as the reasons not to do it entered my mind, there were so many million reasons why I should. The most obvious reason on why I should do it was I was not happy. The world assumed I was. Hundreds of photographs of my husband and I on local and international holidays, selfies taken at an angle that didn't show my double chin, and my numerous journalism awards posted on social media gave the world an impression that I was happy. The world thought I had it all. That was not true. I hated looking at myself in the mirror each day. I hated the acne scars on my face. I hated my plump cheeks, my double chin. I hated that I couldn't wear fashionable jeans and my hair was coarse. I hated that I wasn't really confident and put on a front. And for a long time, I convinced myself that being overweight was okay and that I shouldn't body shame myself and that I was more than weight. The reality was that my body only showed how ill I really was. It was never really about the fat. It was about what the fat reflected and symbolized. It showed a woman whose body was out of control, and that was the reason why I battled to get out of bed every morning. It was the reason why I hated socializing, and it was the reason why my whole life was out of control. The fat showed that I wasn't in control. Pcos was. Good evening, everybody. My name is Nivashni Nair Sukdhev. I'm a journalist, a mother, the author of a book called What's on My Mind, Making Babies. But tonight I talk to you as a Pcos warrior. I'm sure that many of you, as you heard that excerpt from my book, are probably nodding and you resonate with it. But I'm here to tell you my story with the hope that it inspires you to know that I took on Pcos and I won. In 2014, when I was given that diagnosis, after many years of already knowing that I had Pcos, I decided to take it on. I started menstruating at the age of 9, and a few months later in 1989, that was the year, I had to see my first gynecologist. I was told I had polycystic ovarian syndrome, but at that time, doctors didn't know a lot about it, and I was told to go on the pill. Unfortunately, my mother didn't think a 9-year-old should be on the pill, so I didn't go on any treatment. And for many years later, I just did not have periods. And to be honest, that was something that it was good. Who wanted a period every month anyway? And it went by for years. And in 2009, I got married. And the discussion on when to have a baby came when I took a negative pregnancy test. But fast forward to 2012, I decided to start looking at fertility treatments, and I was overweight. And I had seen a doctor, and unfortunately, the first cycle of trying to even get an egg couldn't happen, a mature egg couldn't happen because I was so overweight. He was honest with me, and he said to me that he didn't know much about Pcos specifically, and that I should just start a diet. So I went from diet to diet, hiding in my home because I didn't want to socialize, because people asked me 2 questions. You put on weight, what happened? Why are you not having a baby? So I just ignored it. And then in 2014, as you read, as you heard, I was out of control. I was just so unhappy. And I went and I saw my doctor, and eventually I started to diet. But it wasn't a diet in the sense that it restricted me. It was now a lifestyle. I learned how to control my Pcos purely by eating better and exercising. My colleagues got on board with me, and I used to do 5Ks a day, running at the gym. I used to eat properly. I used to think exactly what I wanted, because I now was in a battle and I was going to win no matter what. I lost 28 kgs. And in August, I went for ovarian drilling and I started IUIs. Unfortunately, I went for 5 failed IUIs, and the decision then was to take on IVF. It wasn't an easy decision because the cost factor. As a journalist, I had written many stories of couples who had to take out loans, take extra bonds on their homes. So when you go into an IVF situation, you also have to know that you have to write off some of those costs if it doesn't work. And then there was the emotional side, because you're now doing this, and what if it fails? I've already experienced 5 failures. How would it feel? But I went forward with the correct partner, the right doctor, and a support team like you wouldn't believe. And unfortunately, my first IVF procedure failed, and then the second one didn't, and I conceived. And so I was pregnant and happy, and I now have this baby after I was now pregnant after almost 9 years of trying. And I ended up in hospital for 3 months to save my child, because as the doctor had explained, there was the risk. I had gestational diabetes as well as growth restriction. So I stayed in hospital for 3 months to try and save my child. And he was born at 32 weeks, weighing 1.3 kgs. And then my next step in my journey started, which was being a mother to a baby in a neonatal clinic. So he was premature, and he stayed in NICU for 28 days. And he came home and at 1.8 kgs. And today he's 4 years old. And why I wrote this book is because I started documenting my journey on Facebook. And that is why the book is called What's on My Mind, Making Babies. Every single chapter starts with a Facebook post. And the reason why I started to talk about it is because I wanted to educate people. People needed to know what we were going through, not just our families and our partners, but everybody. They needed to stop asking us, why did you put on weight? When are you having a child? They needed to know why we were struggling. And they also needed to know the procedure that we needed to go through. So, has this book helped people? Most definitely it did. And it's not going to stop, now that the book was launched during Polycystic Ovarian Syndrome Month last year. I haven't stopped talking about it. There are so many Facebook groups. There are so many people out there who have similar stories like mine. And I genuinely believe that if we talk about it, we will educate more. I also want you to know that the first step to fighting polycystic ovarian syndrome is to see a doctor. It is a medical condition. It needs to be treated. Infertility is also a medical condition. You don't just relax and get pregnant at home. Some of us, like me, require science to have a baby. And I think that, the more we speak about it, the more support we have. I have over 1,800 people in my Facebook group. I have many people who have bought my book, and everybody says the same thing. I didn't know you were going through this. I didn't know that you guys had to experience something so traumatic. But the more we talk about it, the more we help people who are not in our situation understand exactly what we're going through. I also want you to know that you need to find your tribe, because I was very lucky in my army to fight polycystic ovarian syndrome. I had my parents, I had my husband, I had a good doctor, but I also had friends and family and colleagues who stood by me. And you need to stick to those people, because those people will raise you up. Those people will encourage you to eat better. They will encourage you to go to the gym. You also need to remember that polycystic ovarian syndrome is not a death sentence. It most definitely is not. And, you know, when I spoke in the beginning, I had said that Pcos, my body, I felt out of control. And today I still do feel that to some extent, because I've had my baby and I kind of forgot all about being on a diet and healthy eating. But at that time, I was in such a bad space that I didn't even recognize myself in the mirror. And I know many of you feel exactly the same. And I want you to know that whenever you think about giving up, remember me. I'm the woman that doctors told would never be able to conceive a child. I'm the woman that some doctors said was one of the worst cases of polycystic ovarian syndrome that they had seen. One had even asked to write about me in a medical journal. I am a woman who had IVF without a period. I am a woman who had 3 surgeries, 5 failed IUIs, 1 failed IVF transfer. I am a woman who prayed for almost 8 years to finally see 2 pink lines, to hear another heartbeat below my own. And I am a woman with a beautiful little boy who calls me mommy. So please, if you think about giving up, I want you to remember me and all the other women who have battled it and won, because Pcos can be beaten. Thank you, Saskia.
Thanks, Nivashni. That was we love your story here, and your book is amazing. And there's a competition to win a copy of Nivashni's book that is just launched on our Facebook page. So make sure you head on over there to enter it as soon as we finish off here. So now it's just time for some questions and answers. If you haven't put your question in the Q&A section, please do now. I'm going to run them past Razina. Dr. Patel, are you ready? Let me try and unmute you.
Unmute.
There you are.
Yeah, I'm unmuted.
Perfect. Okay, so I'm going to start off with the emailed question. So there's some history with this one. This lady's recently stopped taking the pill after using it for about 12 years. After 4 months of stopping, my body has not fallen back into its normal cycle. I went back to my gynae, and after an internal scan and blood tests, she diagnosed me with Pcos. She also noted my lining is too thin. I've been put on Insumax for 3 months and will then check all hormone levels again. My AMH level needs to come down about 4 times. My progesterone is very low at 0.3 nmol per L, which I believe helps thicken the lining and regulates your cycle. I recently visited a natural health practitioner to see if there's anything additional I can do to naturally help my body fall back into a regular cycle. He suggested progesterone cream, 1 ml daily. What are the risks and benefits?
Okay, so there's quite a lot in that. Okay, let's go back to that video. Give me a second. Video coming up.
There
okay.
you are.
So when you have polycystic ovarian syndrome and you have to fix it, so no disrespect to the practitioners you've been to, and I would like to say this is my opinion and the way I've been taught to take care of polycystic ovarian syndrome. So no disrespect to anybody. But if I were taking care of you, I would not only put you on Insumax, I would also put you on metformin. I would then give you the dietary advice and the exercise encouragement that you should have. So I would ask you to have a better lifestyle. So I don't know what your weight is, and you haven't said so, but I would think that almost all people, except the very lean PCOs, would need some degree of lifestyle change, dietary change, exercise. Anyway, it's good for you, even if you're not trying to lose weight. So Insumax alone is not enough. I would do metformin. In terms of your progesterone levels, them being low, you needing a cream, your progesterone levels can be low because you're not ovulating. It is the hormone that increases after ovulation. We don't agree with creams. Conventional doctors don't use progesterone creams. I would think that the best way to sort out these hormones and make your lining thicken, inverted commas, is to address the whole ovulatory issue. So you need to change your whole hormonal situation. And I would think that a degree of preparing your body and a degree of hormonal manipulation starting from scratch. So I would think ovulation induction is the better way to do it, because here you are going around in circles, treading water. I don't see you moving fast in the right direction. So I think you need a complete review of how you're treating yourself.
Perfect, thank you. And the next email question is about hair loss and thinning. Is there anything that can be done to thicken and regrow hair? Mine seemed to get better when I was pregnant, but thinned dramatically post-delivery. I have quite bad male pattern hair loss.
Oh, it's a difficulty, that one. So it can come along with polycystic ovarian syndrome. We have to check your male hormones. We have to manipulate them to normalize them. Other things post-pregnancy that you must think of and which have a role to play is iron deficiency. You also need to look at your thyroid levels. Those also cause problems. Lots of vitamin deficiencies do it as well. So a good multivitamin, iron levels, thyroid, and let's check your male hormone levels and see where you're at.
Okay, great. How can one address hormonal imbalance, especially when one is desperate for a child?
Okay, so if you were present for the slide presentation, the hormonal music that your ovary is making is not adequate to facilitate the growth of an egg to the point of maturity. So we need to give you the medicines to facilitate that, often at a fertility clinic, sometimes at a gynecologist who is not a fertility specialist, but is probably experienced in doing it. So we then need to give you FSH, which is a hormone that tells the ovary to make eggs ready. And when it makes eggs ready, your fertility potential will be restored.
Okay, thank you. And then, is PCOS and skinny PCOS treated the same?
So the skinny PCOS doesn't need to have glucophage and doesn't need to lose weight. They are more likely to ovulate, but they're also more likely to hyperstimulate. So they come with their own issues as well. So they're not treated the same way, and there are special precautions for each and special methods of facilitating response to our medication in each. So they are very different. They have some overlapping issues though, but they are treated very differently.
Okay, and what do you think about, I don't know if I'm going to pronounce this right, inositol as part of management?
So yes, you see there are trace elements that one can find that help manage insulin. So inositol is present in Insumax Q, it's present in, I'm forgetting the name of so those are brand names, all of them contain inositol. So on a chemical level, they facilitate the use of insulin to stabilize glucose. Yes, please find the combinations that it's in and please use it, it is useful. In combination with other things, not on its own. You must do your glucophage or weight loss and all of that. Yeah.
Okay, and then there is a question about weight loss. Is it possible to lose weight with PCOS purely with exercise and diet and without the use of metformin?
So definitely one should try. You don't have to use the metformin. It's just usually for the people who are stuck. But remember that chemically, your insulin levels are elevated even just from overweight. The woman who doesn't have Pcos but is overweight, your insulin levels are elevated. So when you are an overweight person with Pcos, you're trapped by the high insulin levels, and it will serve you well to use it for a short time even. So I like using it. It actually just encourages people to do what they're doing, but you don't have to stay on it. So I would say it's a good thing to use. Try if you can. Don't get frustrated. Use it when you feel that you're going nowhere.
Okay. Thanks, Dr. Patel. And how common is spotting? I stopped the pill and got a period the month after, didn't get one for 2 months after that, and then started spotting for weeks with only a few days of no spotting in between.
Okay, so all that points again to a lining that doesn't know what it should be doing. Because in a normal cycle, the estrogen that's produced in the first half of the cycle and the progesterone that's produced in the second half of the cycle tell the lining exactly what to do and when to bleed. So when it bleeds, it's actually losing its footing and it's bleeding because the chemical messages are telling it exactly what to do. So an imbalanced lining is what you get spotting from. And an imbalanced lining is because the chemicals are imbalanced, the hormones are imbalanced. So it is the same thing that you're working with. A body that doesn't know when to have a withdrawal bleed and when to stay in. So let's review your hormones so that we can fix the no period and the spotting all at the same time.
Okay, we've got time for one last question. The ones that we don't get to this evening, please will you email them to me, saskia@ifasa.co.za, and then I'll put them to Dr. Patel and she'll reply and I'll send them on to you. So if we don't get your questions, please send them by email to me. The last question, Dr. Patel, is I wanted to ask, I have PCOS and blocked tubes. I've had 2 failed IVFs. So I joined some PCOS group and they are using Inofolic and Insumax Q now. The problem is I tried the Inofolic and I lost weight and I'm naturally a slender person. What can slender women do to maintain their weight while fighting PCOS?
So there's a lot in that as well. I started off concentrating on the fact that we've got blocked tube and PCOS, then the failed IVFs, which I'm saying we need to deal with, but the question eventually came down to be, how do I maintain my weight? So my thought process is a little all over the place. In terms of maintaining your weight when you're a slender PCOS, I think everybody who needs to get muscle toning and good nutrition in to build muscle bulk must do that. So a lot of people, when you're slender, I think you take advantage of your good constitution and you eat unhealthily thinking that you won't put on weight with it. So I think that you should start looking at nutritional value, the nutritional value of the meals you're eating. You're probably eating too little protein and too little of the good food groups. So I would say putting on weight has got to do with your selecting nutritional foods that will help you get to the goal you want to achieve, which is be able to ovulate and carry a pregnancy well and help that your baby's metabolism while it's in you to be healthy as well. Exercise is always good. Toning muscles is good. We were built to walk on the plains and climb mountains, and we just sit in cars and we watch TV. So exercise, lots of fluid intake, and a nutritional diet, nutritious diet.
Perfect. Thank you. So that's all that we have time for this evening. As I said, please email your questions to me if we haven't got to them in this Q&A session. So thank you to everyone for joining us on our second webinar for RHM 2021. On Tuesday, we'll be online once again at 6 p.m. talking all about male reproductive health, including whether having had COVID-19 impacts your fertility. So please register or get your partners to register at reproductivehealthmonth.co.za. Thank you, Dr. Patel. Thank you, Nivashni, for giving up your time this evening. We really, really do appreciate it.
Thank you for having us. It's good talking to you. Bye-bye.
Okay, keep safe. Bye.